This Week in Virology, the podcast about viruses, the kind that make you sick. From Microbe TV, this is TWiV, This Week in Virology, episode 789, recorded on August 3rd, 2021. I'm Vincent Racaniello, and you're listening to the podcast all about viruses. Joining me today from Ann Arbor, Michigan, Kathy Spindler.
Hi, everybody. Here, it's a pleasant 76 degrees Fahrenheit, which is 25 degrees Celsius. Blue sky with some nice Springfield puffy white clouds.
It's 24C here, but it's all cloudy. It was really cool this morning. I thought, this is August. It gets cooler. Also joining us from Madison, New Jersey, Brianne Barker.
Hi, it's great to be here. I have basically the same weather as Kathy, actually.
You have clear skies there? Yeah.
We have clear skies here.
Wow. It's all cloudy here. Totally cloudy. I should get a window cam so I can show people. It's all cloudy. I see the George Washington Bridge. It's very cool. And when I go to the studio, I'm not going to see it anymore. I'm going to see the back of a billboard out the window.
Yeah,
that's the classic.
That is a bad part of it.
Yeah, but, it's life. You got to move on. Also joining us from Austin, Texas, Rich Condit.
Hi, everybody. 88 degrees, mostly cloudy. It rained like crazy all day yesterday, so it's really wet today. We got 65% humidity, dew point 73. So it is stickier than usual. However, I would say that we are experiencing a fairly moderate summer in Austin. We have a lot of excess rainfall. We've only had 3 days officially over 100 degrees. Looking 10 days out in the forecast, I don't see anything over 94. Okay, so I'm not complaining. Well, I am kind of a little bit inside, but not a whole lot.
And we don't get a lot of over 90 degree days here, for sure. And today it distinctly felt, when I went out this morning, it distinctly felt like almost fall. That's that August feeling. It starts to feel like fall, and you're like, what happened to the summer?
I think it's going to be summer again next week.
I shouldn't complain. I'm always inside. What do I care, right? Which is fine. I don't mind. So, Kathy, what's up with the ASV vaccine town halls?
Oh, well, we're having them. There are a whole lot of them. And we have at least 6 of them planned from when this episode drops, from August 5th to August 19th. So if you know of people who still have questions about the vaccines, point them to asv.org/education for the free town halls. Questions asked will be mostly answered, except where the answers are science that we don't know the answers to yet.
Or I guess based on the last one I did, if we run out of time.
Yeah, there's that.
All right. Yeah, Rich, you put a little graphic in here. What's up?
Yeah, months ago in the pandemic, I used to give sort of almost a weekly summary of what was going on in Austin. I was particularly taken with Austin Public Health's approach to monitoring this, because in particular, given the vagaries of testing, what they chose to do was to track COVID hospitalizations in the metropolitan statistical area, which is the 5 counties surrounding Austin, including Travis County that contains Austin. And then they have a staging thing where they have different colors if you're over a certain amount of hospitalizations. It triggers different recommended levels of protection. And I haven't talked about this for a long time, but their curve, well, it's classic. I mean, you can see it all over the U.S., but I have to say that recently we're up in the red zone again, stage 5, the most urgent stage. And the trajectory is going straight up, just like the others. Okay, so it's a different demographic in a way. Okay, and I don't know what the death curve looks like, though I assume that it's different than previously. because a lot of the people who are most susceptible have been vaccinated. But in terms of virus load in the community, this looks every bit like previously.
What's the percent vaccination in Austin? Do you know?
I don't know about Austin in particular, and you'd have to look up. You'd have to look it up.
There's that app that Kathy picked a few weeks ago. You can drill right down,
just
right?
last week, yeah.
Last week.
I don't. It's not horrible in Austin. It's probably about average. Okay, but actually, this is one of the things that gets me. You know, when we were coming out, when we were really on the downswing from the last peak, one of the things that we talked about was, you know, maybe herd immunity is actually kicking in.
Yeah.
I don't think so. Okay. Well, this tells me, I think this is mostly behavior. Okay. Yeah. I think it's a combination of vaccine and not taking appropriate precautions. We could talk about that, but my guess is the behavior, those two things, vaccination and masking and distancing, are what really drives most of this. Other factors, we're going to talk about some of that, but, and, apparently, 50% vaccination coverage, even 60 or 70% immune status in the community, if you consider that there's going to be people who have recovered and stuff. I don't know what the actual numbers are, but it's not enough.
Yeah.
Okay.
Yep.
And I don't think, I think my personal attitude is forget about all this herd immunity stuff. And I've said this before. If you're thinking I'm not going to get vaccinated because ultimately the virus will go away, herd immunity will take care of it, you're in for a rude surprise, because that's not happening. This is going to stick around until we're all infected or vaccinated.
Yeah. I think in terms of disease, we'll talk about this. It's important to remember, and Daniel pointed this out, it's a different population now being infected, right? Yep. These are people who pretty much don't want to be vaccinated. They may have different, Daniel said they're probably younger on average, and they may have different comorbidities. So disease comparisons are very hard. Here in New York today was announced you're going to need to have proof of vaccination to go to restaurants and gyms. First city apparently in the world, according to Reuters. So I said to Amy, what do I have to do? And she gave me this app, and I failed because I don't live here. So I'm not going anywhere. I don't go to a gym here anyway. And I don't need to go to any New York restaurants. It's fine. I can get into my studio. That's all I need. But I think that's good. If people really want to go out, they'll have to do this. There's a little app. I forgot what it's called. It is... I have it right here. New York State Wallet. And you need an Excelsior pass. Come on, you got to give it a fancy name.
So I'm wondering, because we don't have anything like that here that I know of. How do you get official information, like from your vaccine card or from your medical record, to be accepted and validated by this app?
This connects with the CDC, where your vaccine information originally went.
Yeah. So
I see.
The place where I got vaccinated had their own thing.
Oh yeah.
And so there's a copy of my vaccine card in my Apple Wallet on my phone.
That's cool.
And so I wonder if I went to New York,
you might,
whether that would be enough.
Actually, they should let out-of-state people in, because otherwise they're going to shoot themselves in the foot in terms of commerce. But it didn't work. They kept saying, we can't validate you. Okay. I'm okay with that.
You might check some other apps because I know that I have mine.
I don't need to do it. It's fine. I don't go to a gym anywhere, and I don't go to restaurants yet. So I actually did go to one in Princeton weeks ago. The textbook authors got together, and we went at a senior hour, so nobody was in the restaurant. We went at 5:00, and it was just us. So we had our celebration of the book, which we hadn't had yet. So I thought we do have a paper for you, which is really interesting today. But before we get to that, I wanted to go over this document, which the Washington Post published. They say it's a leaked CDC slide deck. And who knows, somebody released, because some of the slides are marked preliminary, do not release, but it's out there. I thought we'd go through it and we could chat about it. And I'm going to share this. For you who are listening only, we will explain it sufficiently so that you can understand it. And for others, you can see it. So there it is. And you can still see us on the side. There you go. So it's called Improving Communications Around Vaccine Breakthrough and Vaccine Effectiveness. Looks like there's something redacted here, right?
I'm wondering if that's somebody's
Probably the authors.
name. Yeah.
Oh, okay.
And this was, how did you come by this? Is this linked in that Washington Post article?
Yeah, it's linked in the article. I should say it was sent to me by Jeff, who is the fundraiser I hired for Microbe TV a few weeks ago. He's out in LA and he's very active, and I can text him at any hour of the day and he responds. But he always sends me stuff now, which is not what I'm paying him for. But don't get upset at that, Jeff. I appreciate it because I don't see all the things. And even one of my picks is also due to him as well. So the link is in the post. And if you follow the link, you get a PDF and you can download it. And that's what I have here. And it's got this official CDC thing here. But of course, anybody could have made this.
And the PDF looks like it's a PowerPoint presentation that was presented to some CDC group by somebody. It's an internal CDC presentation. That was my take on this.
Yeah, I think it's as you'll see later, it's all about messaging, right? What kind of messaging we're going to give out.
How do we parse and how are we going to present the current status of things?
So and this first slide is about vaccine breakthroughs may reduce public confidence in vaccines. Vaccine breakthrough cases are expected. And at the end, they say it's important to update communications describing breakthrough as rare or a small percentage of cases. So they're telling people how to message this. Well, that's correct, right?
Yes.
We expect a lot of breakthrough. We expect infections in vaccinated people, right? We don't expect the vaccines to prevent infection. I think we've messaged that a lot here on TWiV.
It's the fire extinguisher metaphor.
Yeah.
The immune system is like a fire extinguisher in your kitchen. It doesn't prevent fires, but you can put them out. Okay.
They say vaccine breakthrough will occur more frequently in congregate settings and it groups at high risk, like immune compromised or elderly and so forth. And one of the bullet points here, the public convinced vaccines no longer work, booster doses needed. So I guess they want to anti-message that, right? That's good. Yeah, you don't want the public to think the vaccine's not going to work. I think that's one of the outcomes of worrying, right?
Absolutely.
Yeah.
Well, and they don't exactly say it in the best way in that previous slide, but I think the gist of part of what they're saying is that because more people are getting vaccinated, then you're going to have, more cases will be in vaccinated people because there are more vaccinated people.
Yes.
Yeah.
So it's something you brought that up yesterday or maybe Friday, Brianne, right?
Yeah. My feeling is that with many of the numbers that are floating around now, you should always ask the question, what's the denominator?
Yes.
All right. So the next one is called Greater Risk of Disease, Hospitalization, and Death Among Unvaccinated versus Vaccinated People, National Estimates. And there are 3 graphs here where we're looking at weekly incidents per 100,000. We're looking at disease incidence, hospitalization, and death. And they're comparing vaccinated in blue and unvaccinated in green. There's a 8-fold reduction in disease incidence, 25-fold reduction in hospitalization, and 5-fold in death. All right.
And so you know what I did with these numbers is I went and I took them and made them all 1 in how many. So for disease, it's 1 in 5,000. And for hospitalization, it's 1 in 1,000,000. And for death, it's 1 in 2.5 million. If I did my arithmetic right.
And is this in the vaccinated individuals?
Yeah.
Yeah, that's great. That's really
Or
good.
looking at it another way, this is completely consistent with the message that we get that greater than 95% of the people in the hospital are unvaccinated.
Yeah.
Okay. If there's a 25-fold, there's a greater than 20-fold reduction in both hospitalizations and death. If it were 20-fold, that means that 5% are vaccinated, 95% are unvaccinated. So it's greater than 95% of the hospitalizations and deaths are in unvaccinated individuals. If that number doesn't resonate with people, then you're just, I don't get it.
So they also have, in some red type here, at current incidence, 35,000 symptomatic infections per week among 162 million vaccinated Americans.
So that comes out to be 1 in 4.6 million.
Yeah, it's pretty low.
So on the one hand, you might see on Facebook or something like that, oh my God, there's 35,000 infections. Okay. But the rate is really small. And in unvaccinated people, it's going to be 20 times that.
Right.
Easily, 25 times that.
Okay. All right. The next slide is a little, it's marked confidential in red, preliminary data subject to change. And I think probably they shouldn't even, well, if this is supposed to be internal, that's fine. It wasn't supposed to be leaked.
Exactly.
Because
Correct.
I think this is not going to end up panning out. But what it is, it's a graph of percent vaccinated persons hospitalized. And this is from the COVID network with January, February, March, April, May. So you have, we have percent hospitalized who were fully vaccinated in yellow and percent in-hospital deaths who were fully vaccinated. And, in January it's 0, and then it starts to creep up. In April it's 3.1% percent in-hospital deaths who were fully vaccinated, and 4.8 hospitalized who were fully vaccinated. And then it jumps up in May. But they say it reflects increases in vaccine coverage, higher coverage in older adults, right? And the high risk among older age groups for hospitalization and death relative to younger people, regardless of vaccination status. So
I would like to see a condition where, in fact, 100% of the hospitalizations and deaths were in vaccinated individuals.
Yeah, that would be good, right?
Yeah, because that would mean everybody was vaccinated.
Yes.
Yeah.
Yeah. I mean, I just feel like this is another place where talking about there are big differences in how many people are vaccinated. And that's what we're seeing here. Needs to be repeated over and over and over again.
We don't know what the numbers are here. Do you have any sense for what they might be? Is it big numbers or small numbers? Does anyone know?
Big numbers in terms of the
figure out
number of deaths, or
the percentage of deaths and hospitalization in this COVID-net study.
We could probably back calculate it, but we'd have to find some other data.
Yeah. Okay. I'm just curious about how much it is. But yes, if this is mostly older people, it's not surprising because some of them will die, right? And it's a low percentage. And I think there's nothing to say that the vaccine isn't working here from these data, but some people are making a big deal out of this. I wouldn't be concerned about it at this point. I think Rich is right. 100% should be vaccinated. Yep. Then the next slide is about how the CDC monitors vaccine effectiveness, VE, which is the real world effectiveness, as opposed to vaccine efficacy in a clinical trial. They use infection, transmission, cohort among healthcare personnel and frontline workers. That's where they study that. Non-severe disease is case control among outpatients, electronic health record data sets, severe disease and hospitalization in hospitalized patients, older adults, including nursing home residents, 65 and up, National Healthcare Safety Network comparison to population coverage, estimated through immunization registries, outbreaks in nursing homes. What's EHR data sets?
Electronic health records.
Thank you. People with underlying conditions, immunocompromised, duration of protection above, variant-specific vaccine effectiveness, all captured above.
I want to pause here for just a second. Otherwise, I'm going to forget this. But we're going to talk about some papers in a short period of time that collect a lot of data about the Delta variant and how it behaves. And a lot of those the papers come from places other than the U.S.
That's right.
Singapore, Scotland, and Canada.
Right.
Okay. And they all involve mining health records. Okay. And it occurs to me, I'm not sure of this, it occurs to me that that's easier to do in other countries that have universal health care or systems with widespread electronic data gathering, which of course we could never do in the U.S. because it would violate our personal freedom. Okay. But it really speaks to the power of one of the subtle powers of universal healthcare and a widespread electronic data gathering system. It allows you to see easily what the heck's going on.
Yeah. I guess the extent of that here is much less, even though there are electronic health records.
That's my assumption. My assumption. Somebody, I think there's, there are networks, but there's not an integrated national network, as far as I know. Somebody else can speak to that.
No, I think you're correct.
All right. So next we have vaccine efficacy results. Early evidence in healthcare providers that vaccination may reduce transmission and attenuate illness. This is a study, the HEROES Recover study from December 2020 to April 2021. Vaccine efficacy against infection, 91% among fully vaccinated, 81% for partially vaccinated. Compared to unvaccinated, vaccinated cases had either full or partial, 40% lower mean RNA viral load, 2.3 versus 3.8 copies per mil. Let me just ask. Take a nasopharyngeal swab from two people. How can you compare? Are they using a housekeeping gene or something? How can you compare it and say this person is, because it's different amounts, different numbers of cells. Remember in the paper we did last week where they counted the number of cells, single cells, it varies hugely, right?
Yeah.
So I don't know how they would do that.
I don't know either, but we did talk about this study either when it was a preprint or part way through or something, but it was our first hint that there was going to be data showing that having a vaccine might reduce transmission.
Yeah. Shorter mean duration of detectable RNA, 2.7 versus 8.9 days. So that I can buy because that's easy enough to figure out, right? Lower risk of febrile symptoms, 25% versus 63. Shorter mean duration of symptoms, 10 days versus 16 days. Okay. That's all been published, New England Journal. Preliminary, here, this next slide is confidential. Preliminary data subject to change. Preliminary vaccine VE estimates assessing duration of protection for 2 doses of mRNA vaccines. So one of these data sets, the Vision, it's 8 integrated healthcare systems through June 22nd. VE against hospitalization, 88%. No evidence of waning immunity, 16 weeks post-second dose. Then we have a second study, IV3 VE, hospitalization 87%, no evidence of waning through 20 weeks. And then the third is the healthcare personnel, VE against symptomatic infection, 90%, no evidence of waning through 19 weeks. It seems all good to me, right?
All good.
Yeah, all good stuff. The next one, lower estimates of VE for mRNA vaccines among immunocompromised populations. This is all published. 71% against infection, 7 to 27 days after the second dose of Pfizer among immunosuppressed people versus 90% overall. 80% against infection greater than or equal to 7 days after the second dose among people with IBD on immunosuppressive medication, inflammatory bowel disease, and then 75% against symptomatic COVID, 7 to 27 days after the second Pfizer dose, Pfizer-BioNTech among immunosuppressed people versus 94% overall, and 59% against COVID hospitalization among immunocompromised greater than or equal 14 days after the second dose versus 91%. So this is not surprising. These are people who cannot make an adequate immune response, right?
Not surprising at all. But
go ahead, Rich. No, you go ahead. I was just going to say it's not surprising at all, but it also speaks to the fact that it is still very important for these individuals to get vaccinated because they are getting some level of protection, even if it is less than what we see in non-immunocompromised individuals. And you can imagine how much worse disease might be in these individuals.
Right. Not only that, if I'm not mistaken, there's no evidence for any elevated statistic relative to adverse effects or anything like that. There's no downside, and I think a lot of people have this sort of knee-jerk notion that if you're immunocompromised, somehow you shouldn't get the vaccine. It's going to do bad things, and that's not the case. Okay, it's going to do good things. May not be quite as good as if you were fully immunocompetent, but it's a lot better than nothing. And getting the disease, if you're immunocompromised, is the worst possible situation.
Good points. Good points. All right. Lower estimates of mRNA vaccine effectiveness among nursing home residents. Any infection, including asymptomatic, 65 to 75% in different locations and platforms during December 2020 to May 2021. And these numbers are all in the 70s, 60s, and 70s. NHSN, National Health Something Network, 62, 76 years old for Pfizer, 65% for Moderna. Signature Healthcare, I guess these are nursing home companies, right? NHSN and Signature Healthcare, 74% in the 54 to 85 age for mRNA, and LA County, 75%, 43 to 89 years of age.
I think that's a confidence interval.
That's the confidence. Sorry, I thought that was the age. Yes, thank you. So don't ignore the ages that I just gave you.
Nevertheless, these are going to probably primarily be older individuals, probably other compromising issues. So much the same as the immunocompromised population. It's not a surprise that the efficacy may be lower. And anything is better than nothing.
And in particular, nursing home residents. Now, remember, the vaccine trials had some older people, but maybe they weren't in nursing homes, right? And they were healthier in general. So this is the real world, right? VE is the real world. So I think it's not inconsistent with the vaccine trials. The next one is called Vaccine Effectiveness and Breakthrough Example Using the Screening Method.
I did not understand this. It's modeling of some sort or another.
It is modeling, yeah. So they're modeling vaccine effectiveness by comparing vaccine coverage in cases to the population. And they have a formula for that. And this is a recent nursing home outbreak of the beta variant. It's the VE estimate, 61% against infection, 75% against mild disease, and 85% against severe illness.
I think this partially gets at the point that we were making before, where Rich mentioned that he wanted 100% of cases in the vaccinated individuals.
Yeah.
And so here they're showing you the relationship between the percent of the population that is vaccinated and the number of cases in the hospital that would be vaccinated. And they're modeling what that would look like if the vaccine had different levels of effectiveness.
I see. Okay.
And so if the vaccine was 0% effective, then none of the cases would be, then we see that basically nobody would be in good shape. Yeah. But if you have a lot of people vaccinated, then most of the cases in the hospital will be vaccinated. And the exact relationship of how that increases will vary based on the vaccine that we have.
Yeah, so the graph, the y-axis is the percent of cases who are vaccinated, and the x is the percent of the population vaccinated, yeah. And so they'd have individual lines for different percent vaccine effectiveness from 0 up to 100%. Yep. Then the next one is called Vaccine Breakthrough in Long-Term Care Facility Residents, where coverage is 80% nationally. This is, again, an modeling estimate. For infections, 61% cases vaccinated, for mild illness 50%, and for severe illness 38% of cases vaccinated.
Yeah, and so this looks like it's the same model.
Yeah.
But they've now just put the current data on there in order to kind of use that to give them an idea of vaccine effectiveness. Which of these vaccine effectiveness lines does our current data seem to fall on?
And they're using the assumption of 80% coverage, which we're not at, right? But this is in a situation where you had 80% coverage. This is what you might expect. You might expect for severe illness, 38% of the cases who are vaccinated based on their modeling and using existing data.
And it makes the point again that there's going to be a certain amount of disease and hospitalization in vaccinated individuals. And that doesn't mean the vaccine's not working.
No, and it's not an excuse not to be vaccinated, because it'll be worse if you don't get vaccinated, right? So then this is a slide about communications challenges around VE and differential risk. And these are some bullet points. Vaccines are more effective against hospitalization, death, more so than against illness, more so than against infection. It's important to acknowledge lower VE against infection. Although we've always said it right here on TWiV, it's not going to prevent infection, especially the further you get out from the second dose. VE estimates represent an average for a group rather than an individual risk. It's modified by age, immune status, need to clarify messages around individual protection. It's important. How do we communicate this differential risk to the public? Comparisons to unvaccinated that are relatively stable, personal stories, examples from outbreaks. It's an interesting point there, right? Because that's always what Alan says. You got to make personal stories part of your messaging.
So this immediately makes me think, the cynical out there might look at this and be reminded of, leaks of talking points among political parties and that kind of stuff. Yeah. Okay. And I want to emphasize that this is not that. These are effectively conclusions based on science and formulated in a way to help public health individuals communicate what the conclusions are and understand the science behind them. Yeah. Okay. This is not an attempt to pull the wool over your eyes. This is an attempt to communicate the science.
Yeah, all this is based on science for sure. Okay, the next section is called Delta variant.
Dun, dun, dun.
Okay, so the first slide, they took a figure that I actually use in my course. It's from the New York Times, February 28th, 2020, where they have a graph. The y-axis is CFR. They call it fatality rate here, but in the original it was CFR. And then the x-axis is the R0, the reproductive index for different viruses. They have different viruses on the graph. They have, seasonal flu, common cold, chickenpox, measles. Some are really transmissible but not so deadly. Some are not so transmissible but really deadly. In the original SARS-CoV-2, they had fatality rate from 0.1 to 1%, and the R0 was 2 to 3. They call that the SARS-CoV-2 ancestral strain. And then they have a box with Delta variant, which goes from 5 to 8, it looks like. And they say here, they put some text, Delta is more transmissible than MERS, SARS, Ebola, common cold, seasonal flu, 1918 Spanish flu, smallpox. It's as transmissible as chickenpox. Actually, varicella zoster virus. So I don't know where these data come from because they don't tell. As in contrast to what we've just heard, I don't know how they get this. And so I've asked Jeff Shaman to come back next week and tell us how you calculate transmissibility from epidemiological data. It's modeling, of course, but they don't show us that.
In my mind, okay, this is, and we've had this conversation about vocabulary to death. Okay, I think for us, it's more comfortable to use the word spread rather than transmission. Okay, because that in our minds, in our non-epidemiological minds at least, sort of generalizes the phenomenon, whereas transmission implies mechanism, which we don't know mechanism. Okay, but to me, this is somewhere along the line. There's epidemiology here that measures kind of the rate of spread under the current conditions of this.
Yeah.
And it suggests, as I presume the epidemiology backs this up, that under the current conditions right now, Delta is spreading faster than the original SARS-CoV-2. Why? I don't know. Okay, we'll get into some possible reasons, but that's what I take away from this, and I look forward to hearing what Jeff has to say.
So I think that's a good way to put it. As Fouchier said, spread is made up of multiple components, right? It's the intrinsic properties of the virus. It's maybe what we would call transmissibility, but then there's human behavior, right? So I would like to know how they factored in the human behavior and the rate of spread. Because Fouchier said you can't just use rate of spread of a virus in a population to calculate R naught or R, whatever it is. So,
and in terms of describing what changes there might be in the virus, the vocabulary that came out of that discussion was fitness, talking about the virus being more fit, okay, which I think is a nice sort of a catch-all word. That has no really specific implications for mechanism, though Ron had his own ideas as to what the mechanism might be, having to do with immune escape. And you'll be amused, maybe pleased, that there was an expert of some sort or another, public health official, on the PBS NewsHour the other night that, in talking about the Delta variant, described its increased fitness.
Wonderful.
As opposed to transmission. And I'm thinking, whoa, does this person listen to TWiV?
That's good. So so I want to clarify this because I think we're using different terms here for sure. But I don't know if this blue box is going to stay where it is in the textbooks, right? I'm just not sure yet. And there's enough uncertainty out there. In fact, the CDC's messaging is not, it's mixed on terms of transmission, what they call transmission. Sometimes they'll say it appears to be, and sometimes it is, right? And my pick relates to this later. But what I do want to point out, in terms of virulence, it looks about the same as the ancestral strain. That's the y-axis, according to this. So that's kind of
from February.
Yeah, from February, right.
The other thing that we haven't talked about is that, the difference between R and R naught. And, if we're talking about R naught, then I may have this wrong, but I think that it's saying, what the situation is when the virus first emerges and there are no population mitigations or whatever.
Correct.
Right. And the population is naive.
Right. And so, if that's what we're stating here for measles and smallpox and Ebola and so forth, then I'm not sure how we can actually come up with a good number for SARS-CoV-2 because we do have mitigations in play and we don't have a naive population and so forth.
Exactly. That's Ron said the same thing. You can't do R naught when population's got some immunity already. Yeah.
That actually sort of makes me think, I wonder how we have estimates of the other ones without in a naive population as well.
Right.
I think it's very hard. And also, so the R naught in itself is difficult because it depends on how many people are in the group you're studying, right? If they're small households or large, because that would affect it, right, as well. And I think R naught really shouldn't be viewed as a constant. I think, this kind of a graph is a bit misleading, saying, it's exactly 2 to 3 for this virus. I'm not sure that that's the case. The other thing I wanted to point out is that another way of measuring transmission or spread is secondary infection rate, right? The number of people who can be infected by an infected person. That's been done a lot. And a couple of weeks ago, the report out of Public Health England, the secondary infection rate for Delta went down, which probably reflects what people are doing in some way, which tells me that I think is underscoring it's not an intrinsic property of the virus, or not entirely, that they're looking at, because if it changes, it by definition can't be, right? Anyway, hopefully we'll have a good conversation with Jeff about this next week. But, he's going to have the epidemiological viewpoint. All right, so now we have some data here, which I have some issues with. Delta infections associated with higher viral load and duration of shedding, published evidence. And India report of lower cycle threshold values in Delta breakthrough cases in healthcare workers, 47 people, CT value 16.5 compared to non-Delta breakthrough, 22 people, mean CT 19. Also larger cluster size with Delta breakthrough. So the cluster size, I think, is impossible to compare, because it just could be that there were more people in the one outbreak than the other. CT values, I don't know how you can compare them between people, right? Because as I said, you're not standardizing the nasopharyngeal swab. And of course, it's RNA. It's not infectious virus, which I can imagine that a variant would be different in the amount of RNA it makes in a cell compared to infectious virus. So I think, and to this day, nobody has ever measured infectious virus shedding in Delta versus ancestral, which I think would really clarify it for me anyway. Anyway,
or as one of the listeners said, the particle to PFU ratio.
That is great point. Yeah. Delta infection, second bullet point, Delta infection associated with longer duration of CT less than or equal to 30, median 18 days versus 13 days. That's something that Daniel mentioned a couple of weeks ago. And the risk of reinfection with Delta may be higher compared to Alpha, but only if prior infection was greater than 180 days earlier. And the adjusted odds ratio is 1.46, okay, with a confidence interval of 1.03 to 2.05, which I would say it's from none to some to twice as much, right? I think that, I don't know. Thoughts on this stuff? Any ideas?
I'm waiting until you get down to the one. Is the next slide the one with the 3 references in it?
No, it's maybe more severe. One more. Anyway, so I think these are squishy. This is squishy data here. I'd be careful, because I think you got to be really careful with PCR data. And I want to bring up again, I mentioned this on Friday, this paper from New England Journal that Daniel talked about on Thursday. They were looking at infections in vaccinated versus unvaccinated people with Delta. And they said as high PCR, viral loads by PCR in both vaccinated and unvaccinated. Sorry, that was the Massachusetts study that CDC is going to cite below in what they're using for saying to mask. But in the New England Journal, it said, of those people who are vaccinated that get Delta PCR positivity, over half of them don't have any antigen. So something is going on there. I don't know. It's not a real infection. And so you can't just use PCR levels, I think. That's my view. Your mileage may vary. I just think PCR is not the right way to look at this. Okay. Next slide. Delta variant vaccine breakthroughs may be as transmissible as unvaccinated. This is the Massachusetts study. Right. Barnstable County, Massachusetts. No difference in mean CT values in vaccinated and unvaccinated. I think that's not right. I just don't think that's right. Okay.
Well, the difficult part is that if you actually look at those data, they show basically a curve for those CT values. And they show that the CT values are very similar at early time points, and then they diverge dramatically as time goes on. Mm-hmm. And so the sort of that question of what does it mean if your CT value is the same at day 1, but then is way higher, which means you have less virus at day 2 or 3. Does that mean that the virus, you were infected with the same amount, or you're just sort of exposed to the same amount and you correctly fought it? Is that an indication of some amount of residual RNA, as Vincent mentioned? And so that was the thing that really struck me, was looking at that curve and seeing how quickly the data diverged, and that this no difference was really concentrated at just the early parts of that curve.
So how, Brianne, I did not look at those data. How would describe the divergence?
So basic, I'm not sure that I can.
This is the MMWR. You want me to put it up?
Yeah. So if you actually look at the data, you can see the day following infection. And so they have CT on the y-axis and they have days on the x. And so in the vaccinated individuals, you kind of see this high, these CT values that then go to higher CT values. They actually, I misspoke. They said they put the viral loads, so it's inversed, and you see a crash in the amount of virus in those individuals right away. Whereas you can see you don't really have the same crash in the people who were not vaccinated. And so if you look at the early time points, they are the same, and it's very obvious. And then suddenly you have, one line that's sort of going straight across and one line that's going completely down.
Now that you've described that, that's not it.
No, I'm pulling it up myself.
No,
too.
This is not the MMWR for the Massachusetts. The Barnstable doesn't have that. I don't know.
Right.
I don't know which one we were looking at.
You make an important point, is that when during the course of disease or infection are these points being taken?
Right.
And is that factored into the calculation?
Yeah, I think for all these reasons, the CT comparisons are very difficult. There's another bullet point on this slide. It says breakthrough cases reported to national passive surveillance have lower CT by 3 cycles for Delta compared with Alpha. I don't know what that means in terms of infectivity, if anything. That's where I'm just worried. That slide is also confidential. Preliminary data is subject to change.
If you want to move on and have me send it to you later, I'm happy to do that.
Sure, we can do that. All right, now, next slide. Delta variant may cause more severe disease than Alpha or ancestral strains. Published evidence. There are three publications cited. They're not all published. One of them is, I think 2 of them are preprints. And as Alan would say, it's not published. Anyway, there's one from Canada. Higher odds of hospitalization, ICU admission, and death, which are the odds ratio they give you. So hospitalization, 2.2, ICU, 3.87, death, 2.37. Singapore, higher odds of oxygen requirement, ICU admission or death, odds ratio 4.9, and pneumonia odds ratio 1.88. In Scotland, higher odds of hospitalization 1.85. So, did you have any thoughts about that, Rich?
Am I correct also that I'm forgetting here, and I don't have the papers right now. Some of these had some CT values and stuff in them as well, as I recall.
Let's take a look here. So the medRxiv is progressive increase in virulence of novel SARS-CoV-2 variants in Ontario. So they actually looked, they created a retrospective cohort of people in Ontario who tested positive and screened for variants with dates of tests between February and June. They conducted mixed effects logistic regression models with hospitalization, ICU admission, and death as outcome variables. Models were adjusted for age, sex, time, comorbidities, and pregnancy status. So they say that compared to non-VOC variants, the adjusted elevation in risk for N501Y positive variants, 59% for hospitalization, 105% for ICU admission, and 61% for death. Increases with Delta were more pronounced. So the others were for any variant with N501Y. For Delta, 120% for hospitalization, 280% for ICU admission, 137% for death. And so they conclude there's been a progressive increase in transmissibility and virulence, which I think is lumping 2 different things together and isn't really fair. So I'm not sure. I mean, this is not published. I'd like to see it get through pre-review.
And then we have a paper from... It's a report
Singapore.
From Scotland. Let's do Scotland.
Okay.
That does a similar type of analysis, looking at both vaccine effectiveness and outcomes vis-a-vis hospitalization, severity of illness.
Yeah.
They show that the Delta, and it's similar sort of thing, looking at medical records and what virus was there and outcomes.
Mm-hmm.
We show that the Delta variant of concern in Scotland was found mainly in younger, more affluent groups. That's interesting.
Yep.
That's changing dynamics. I think that's a behavior thing, including vaccination. Risk of hospital admission was approximately doubled in those with a Delta variant of concern compared to Alpha, with risk of admission particularly increased with those with 5 or more relevant comorbidities. And then they said basically that the vaccines remain effective equivalently effective against the two. And then, so this is another paper that comes to the conclusion that the Delta variant, which has spread faster in that population recently, has overtaken the previous variants, results in, according to their analysis, a worse outcome measured in terms of severity of illness, hospitalization. And then there's the Singapore study,
yep,
which I thought was remarkable, among other things, because they've been able to do such a thorough job of tracing and sequencing from the get-go.
Right.
And they also talk about having it being a relatively homogeneous population that would then tend to minimize those sorts of population variables. And they come to a similar conclusion, that the outcomes are worse.
Yeah.
That the odds ratio for hospitalization, severe disease, are greater with Delta than the others. My takeaway from all these is that these are 3 independent studies in very different locations where Delta has taken over, and they all come to a similar conclusion, that the outcome is at least somewhat worse.
Mm-hmm.
So that gets my attention, put it that way. At the same time, personally, I think we don't know. I mean, a lot more needs to be done. We don't know any reasons. And I think this gets, in my personal opinion, way overhyped in the media, because we also don't know. I mean, the problem right now is that cases are on the rise. Okay? And hospitals are becoming overwhelmed again. And this gets conflated with the circulation of the Delta variant. And the implication is that the Delta variant is driving this. And to me, even if all of this other stuff is true, it's not necessarily evidence that Delta is a major contributor to the increase in cases we're seeing now. That's my most important point, because I think that the tendency there is to minimize, inadvertently perhaps, the contribution of behaviors such as vaccination and masking. And in a way, it doesn't matter anyway, because the only mitigation recourses we have are masking and distancing on the one hand and vaccination on the other hand. Doesn't matter if it's Alpha or Delta or Beta or whatever.
That's right.
Okay?
Right.
That's right.
There's a limited amount that we can do.
Yeah.
And there are things that we can do. Get vaccinated. Stay away from each other.
I flashed back to the figure that you showed in the beginning of Austin, where I wanted to ask you what were the times of the previous 2 peaks. But again, it doesn't matter. Those peaked, and they were without there being a Delta variant.
Yeah,
they were behavior.
That's right.
We came indoors, we let up on the mitigations, whatever. And so it's the same kind of thing. And
and nobody's saying that the vaccine is not effective against Delta.
No.
Okay. You get small decreases in efficacy. I don't know, in some studies, I don't know if they're significant or not. So the what needs to be done doesn't change.
No.
Get vaccinated.
Right.
And in a situation where the sort of in your community, the virus load is going up short of vaccination, which is what really needs to be done. We don't need to be in this situation. Okay. Mask up, practice distancing.
In fact, the Scottish paper, obvious. The Scottish paper, Rich, these findings provide a strong impetus for rapid implementation of vaccination programs.
Yeah.
Anytime.
And I thought the Singapore paper was also quite well written. They did not go overboard. They were very measured in their conclusions and their analysis, and they, basically come to the same conclusion.
But the other thing is, in the Scottish study, as you said, these infections are in younger, more affluent groups. It's a different population. So I think it's hard to compare the disease in different populations. You really need to be careful with that. So as you said, it is not a conclusion yet. Now, Rich, you said no one is saying that Delta gets through vaccines, but I think in this slide, CDC thinks it is because of the PCR loads are the same, but I think this is wrong. This Barnstable County, I think it's wrong.
So I found the data.
Okay.
So it is actually from a medRxiv preprint, another Singapore study. Called Virological and Serological Kinetics of SARS-CoV-2 Delta Vaccine Variant Breakthrough Infections.
You want to show
a multi-center cohort study? Sure.
I'll stop sharing here.
I believe you can see.
Yeah.
So this is the plot that I was talking about, where they look at the unvaccinated and vaccinated individuals, unvaccinated in red, vaccinated in green, and the CT values at different days of illness. And they actually have a statement that says CT levels are the same at early days following infection. But then they go on to talk about how they are not the same later on.
Mm-hmm. So in the vaccinated, they go way down. Yeah.
Right. Exactly. And so this was put on medRxiv at the same time as those CDC data. And I think that this was something that people have been thinking might have been related to sort of behind that bullet point that was uncited.
And look at the scatter.
Yeah.
Yes, exactly.
Oh yeah.
But this is Brianne. This is great. This is really cool. And I was thinking about this morning. I don't know why.
This is
I was thinking about it.
If anyone wants to see it.
Okay.
I don't know why I was thinking about it in this way, but it's like that's it. It fits the fire extinguisher analogy. Okay.
Exactly.
In both cases, you start off with a blaze, and in the vaccinated people, you put it out faster.
Right. That's exactly how I looked at that. And it said to me, okay, so, I think that this is telling me that the vaccine works. And so I was sort of annoyed when I saw the CDC document that said vaccine or the CT levels are the same, because I had seen these same data at the same time and said, yeah, they're the same sometimes. And at other time points, they're really not.
So, and it speaks to Vincent's point about how it's difficult just to look at raw CT value data.
Exactly.
You at least have to know when during the illness the sample was taken. Okay. That it's the kinetics are certainly as important as anything else. That's Brianne. That's great. What a great find. I like that.
All right, so let's wrap this up here. The next slide, Pfizer 2-dose vaccine effectiveness for Alpha versus Delta. So they're looking at confirmed infection, symptomatic disease, hospitalization, or death. And from my perspective, the two are pretty much the same for hospitalization and death. High 90s vaccine effectiveness. That's all that matters to me. I don't care if there's a divergence in confirmed infection or symptomatic disease. In Israel, a big difference between Alpha and Delta. But in disease, it's similar, and that's all that matters. Canada, though, similar numbers for symptomatic in both vaccines groups. So there's all kinds of scatter here, too, right?
Yeah, the differences that you see for Israel don't play out in Canada or England,
Scotland, no. Then this slide says, given increased transmissibility, lower vaccine effectiveness, and current vaccine coverage, NPIs needed to reduce transmission. Well, that's the problem. Given increased transmissibility, if you're assuming that, then they have some models here for masking. Models. What would happen at 2 different R naughts, 2.5 and 5? No masks, unvaccinated only, all masking, and you can see different outcomes. These are models, right? And it's just masking. It's nothing else. They're assuming a vaccine effectiveness of 75 to 80% for just infection, but I don't think infection matters, right? All right, so what is the difference between these two slides? It's the same, isn't it?
I think
it is.
I think it's
it's an overlay.
It's essentially an animation. Yeah.
Yeah. Given higher transmissibility, current vaccine coverage, universal masking is essential to reduce transmission. Yeah. Well, we shouldn't have stopped masking, right?
They don't even have to say to reduce transmission of the Delta variant. They should just say to reduce transmission of SARS-CoV-2.
I agree. I think the focus on Delta is crazy. The press is saying Delta drives everything.
It's a scapegoat.
Yes, a scapegoat, and I think it actually compromises the message, because you're going to have people saying, "Oh, well, there's nothing I can do about it."
Yeah,
because it's the virus that's doing this. Probably the vaccine doesn't work as well. The masking doesn't work as well. I may as well just go out to the bar and drown my sorrows. Not true.
All right, summary slides I really have a problem with. Summary: Delta is different from previous strains. Okay, it's not a strain; it's a variant. CDC. Even the press has got that. It's highly contagious, likely more severe. Breakthrough infections may be as transmissible as unvaccinated cases. I would object to all 3 of those, but this is an internal document. Fine. Bullet point 2, vaccines prevent over 90% of severe disease, but may be less effective at preventing infection or transmission. I don't care about infection. Transmission, I don't buy it. Therefore, more breakthrough and community spread despite vaccination. I don't agree with that. NPIs are essential to prevent spread. Okay. I think you're going to have a problem getting people to go back to NPIs, frankly, since you told them to stop. And so many people don't want to do it to begin with. I think you have an issue.
We just had some changes around here, and the number of messages I have received from friends who are up in arms and who, are upset about that has really surprised me.
We had the announcement that faculty, students, and staff will all have to be vaccinated, which contradicts what I had heard earlier could even possibly be the case, because I had heard that the legislature said, you do that, no funding. But they somehow figured out around that. Yeah.
Finally, next steps, communication. Acknowledge the war has changed. I disagree. The war has always been vaccination. Improve public's understanding of breakthrough. Yeah, don't call them breakthrough. They're infections that happen when you're vaccinated. Improve communications around individual risk among vaccinated. Risk of severe disease is reduced 10-fold or greater in vaccinated. Risk of infection reduced 3-fold. I don't think you should message risk in infection reduced 3-fold. You should say human vaccines do not, in general, prevent infection, and SARS-CoV-2 is no different. That's what I would do, but I'm not in charge of anything. Consider vaccine mandates for healthcare workers. Okay. I think that's a good idea, but a lot of people are objecting. Universal masking. Okay, that's it. Acknowledgements are all redacted.
I think one of the comments that I read somewhere was that CDC did not adopt, in terms of messaging or whatever, all the recommendations from that presentation. That was the author's recommendations.
I see.
And what actually was done was, deviated from that at least a little bit. So I wouldn't, on a leaked document, I wouldn't necessarily take home that those messages at the end are what the CDC is saying. I would say that was what the presenters in that particular presentation thought ought to be said. Go to the CDC to find out what they're saying. And also, with respect to this, hindsight is 2020. We never should have unmasked. I'm willing to give them a break on that. If you look at that same curve that I showed at the top of the show about what was happening in Austin, the cases were plummeting. And even, we were talking even with Daniel about how, maybe this is herd immunity actually kicking in.
Yeah, sure.
And part of the CDC's rationalization, okay, even stated, as I recall, in their guidelines, modified guidelines at the time, was that maybe if we tell the vaccinated people that they can take off their masks, they never said the unvaccinated people could do it. They said maybe if we said that say that the vaccinated people can take off their masks, it'll provide an incentive to get vaccinated.
Yeah, right.
Okay. That was a gamble. It didn't work. Okay. And, the CDC said the unvaccinated people need to keep masking. Maybe if they had, that it would have worked. Okay. Maybe that would have been okay. And maybe it should be an incentive. They did the best they could at the time. Turned out to be the wrong thing because they said vaccinated people can take off their masks. And so everybody took off their masks. And, I go around the store. We were in Trader Joe's the other day, and the masking was at about 50%. And my wife and I are looking at each other and figuring, I'll bet you all the people wearing masks are the ones that are vaccinated.
Mm-hmm. I think they did not estimate human nature very well.
Exactly.
Yeah.
And
exactly.
It seems to me that I could have told you that, people who aren't going to get vaccinated are going to not wear masks as soon as they have the opportunity to not wear masks.
Yeah, agreed. And I thought it was a bad idea, but I'm not in charge. So.
That's because you're so cynical. You knew that the unvaccinated people would take off their masks.
Well, I do think that they should have factored it. They trusted people, and you can't do that. Especially this country is so divided, right?
Yeah.
Maybe 40 years ago, but not today.
That's actually the most disappointing thing. And frankly, really, literally, politics aside, okay, what's disappointing is that over something like this, that obviously doesn't care what color you are, what your religion is, what your politics are, it's going to kill you regardless. Over something like this, we can't come together and do the right thing. Wearing a mask is not difficult. It's just not difficult. Getting vaccinated, there's no downside. It's easy. Why all the fuss? Okay? When the Japanese bombed Pearl Harbor, people came together. Okay? In a way, this is, if you want to use the war analogy, it's the same thing. Come together. Fight a common enemy.
Yeah, but we were divided. Some people were told, you don't have to do it. What CDC is telling you, you can do your own thing, blah, blah, blah. You don't have to get vaccinated. It's a real problem. All right. I wanted to do this paper because, the narrative on SARS-CoV-2 vaccines and recovered people, you take their serum and you test for neutralizing antibodies. You do some kind of infectivity assay where you add the antibodies and you see the antibodies blocking infection. And this has in some ways been a measure of how good our immunity is. But this paper shows that even an antibody that does not neutralize virus in cell culture in the laboratory can still protect against disease by a different mechanism. And I would argue that it could apply to SARS-CoV-2. We just don't know. And, so people freak out, waning immunity, waning antibody levels even. They don't even bother with the T cells. Waning antibodies. Maybe it doesn't matter. And so this is the mechanistic basis of protection by non-neutralizing anti-alphavirus antibodies from James Ernest, Autumn Holmes, Catherine Bassor, Matthias Mack, David Fremont, and Michael S. Diamond from Washington University in St. Louis and University Hospital in Regensburg, Germany. By the way, I was at Hamilton, Montana, some meeting a couple of years ago, and David Fremont was there. He came up to me, he goes, I just love what you're doing with TWiV. It's great. Thank you, David. So this is a model system, right? They have used an alphavirus infection of mice. And the alphavirus, these are RNA viruses plus-stranded RNA viruses. There's a lot of them. There are two classes. There are the ones that cause encephalitis, and then the ones that cause arthritis, joint pain, and so forth. Encephalitic versus arthritogenic. So the encephalitic ones you may have heard of, Eastern, Western, Venezuelan equine encephalitis viruses, right? They're neurotropic. The arthritogenic include chikungunya virus, one of the favorite names, Ross River, Onyongyong, and Mayaro. And Mayaro virus is the subject of this paper. Circulates in the Caribbean islands, South America. Febrile illness, you get joint pain. You can get pain the rest of your life. Chronic arthritis, very much like chikungunya can do. No way to prevent infection, no way to treat it.
So Vincent didn't mention that these are enveloped viruses as well. So they're positive sense RNA viruses like coronaviruses, and they're enveloped like coronas.
May I have the envelope?
And, in cartoon style, at least, even actually more than cartoon style, and in terms of lifestyle, they bear a resemblance to coronaviruses. I mean, if you show a cartoon of it, you got this big spiky thing sticking off the surface that's got the receptor binding domain. Is it a class 1 fusion protein, Vincent?
It is a class 1, yeah.
Okay, so mechanistically similar, at least, in terms of getting in.
There's a
By the way, I really like their introduction to this paper.
It's very
It lays
good.
all that stuff out very nicely.
There's a precursor to this paper, I forgot the journal, a couple of years ago, where they isolate monoclonals against Myarovirus. And they have a mouse model of infection. They have a bunch that neutralize infectivity in cell culture. None of them protected mice against infection. None of them. When you give the antibodies to the mice and then you infect them. So that stimulated this paper. And I was wondering, this is the mechanistic paper, so that's why we're doing this one. So here they isolate monoclonal antibodies that bind to the glycoprotein of Myarovirus. They identify them by binding by ELISA. Then they do neutralization assays. And they picked 13 on the basis of cross-reactivity with other, with different isolates of Myarovirus, basically. They do neutralization assays. None of the 13 that they picked had inhibitory activity in cells, even at 50 micrograms per mil. Can you imagine their disappointment? Or maybe they were happy, actually. They didn't neutralize. And they bound virus particles. These antibodies bind the virus particle. In fact, there's a section where they actually map the epitopes of the for the antibodies on the virus particle. They do an amazing amount of work where they actually do alanine scanning to map the epitopes for the monoclonals to bind, and they can say, okay, there are 6 different sites where they bind, and this is exactly where they bind. Okay.
So in terms of actually doing the science, it would be fun to talk to the authors about this, because I'm an idiot. And if I got this far in the thing, I would say, okay, those antibodies are useless. Throw them out. But they did the smart thing. Chance favors the prepared mind, right? Though I don't know if it was chance. Maybe they were looking for something like this.
Well, I think the previous results were none of the antibodies were protective, right? They made them and they weren't protective, so they say, let's figure out what's going on. Yeah. So they have a mouse challenge model. They take 4-week-old mice, and the virus doesn't cause disease in immunocompetent mice, so they have to give them an antibody against the type 1 interferon receptor. Transiently immunosuppresses them. And then you give them subcutaneous virus and they die. So now you can ask, can you protect the mice with these monoclonal antibodies? So they do. In fact, the monoclonals protect, but they're not all the same. Some of them have 100% protection, some of them 50% or so, and some of them less so. And the protection seems to correlate with the binding affinity of the antibody for the particle, which they measured previously. I didn't tell you that because you would forget it in a moment and it wouldn't mean anything. But the better protectors are high affinity, and they map to one of 2 epitopes. One group at the top of the spike trimer, and another in the linker region on the side. So there's a difference in protection, but they do protect. These did not neutralize in cell culture. So I want people to understand that neutralization is not the only way that an antibody can protect. And this is likely not just for alphavirus. It's not just for myrovirus. It's probably for many viruses as well. This happens to be a great system where they can use it to point it out. So they have the next set of experiments. How does this work? What's going on? How do these protect against disease? So they say it must be the FC portion of the antibody, the part away from the antigen combining site.
You can look at Kathy's model in the background.
Yeah, Kathy's got her. Where is it? There it is. Yeah, hanging up there. We got the Y, right? The two tops of the antigen.
Gotcha.
Yeah, and the bottom is the FC, which combine receptors. And so, if you're using IgG monoclonals, they will bind a FC gamma receptor, and they have mice that have been knocked out and don't make those. So you infect them, you ask, can the monoclonals protect? No protection now. Without an FC receptor, no protection. Isn't that beautiful? A lovely experiment. In fact, the whole paper is lovely.
I'm thinking about the FC portion for people who, don't think about this all the time. I'm thinking about the binding portion as, it gloms onto the antigen, and the FC portion is kind of now what? Okay.
Yeah.
What are we going to do with this now? And that directs the fate of that complex. Is that fair, Brienne?
Yeah, there it is.
Oh, beautiful.
It is. And I think that the other thing that this, tells me is that this tells us that there's a cell involved too. A cell with an FC receptor is doing something.
Of course, yes.
Is that antigen Velcro bound in there or something?
It's a snap.
Yes. I have the same one with different colors, and the detachable antigen that fits on either arm is great.
Kathy's
the
holding
important
up
part is the FC receptor, which in this depiction is the top.
The top, yeah. They got the eyes oriented so that the FC is on top. Maybe they worked on FC receptors. They want to give it prominence, right? I mean, FCs.
Yeah.
All right, so the FC receptors are important for protection, and so then they do some engineering of these monoclonals. They swap them around, and it's a reagent that we're going to use later. The one that I really like is they introduce an amino acid change in the FC region that prevents a glycosylation that you need for binding to FC receptors, and they show that antibody doesn't protect anymore. One amino acid change, and that's going to be used later. They also do some swapping. I don't want to talk about those. It's a bit confusing. The glycan change is really good control. All right, so they have another model. Now they say, we wanted to try a more physiologically relevant model because we had to immunosuppress the mice, right? So it turns out if you give sub-Q virus in the foot of immunocompetent mice, you get joint swelling, you get musculoskeletal disease that you can measure. You can do sections and look at the pathology, or you can measure viral RNA levels. So they can then put virus in with or without monoclonal and say, do we get disease? And do we get dissemination of the virus? So that's a good model. I mean, the mice don't die. You have to work harder to find evidence of virus reproduction, but it's a physiologically relevant model because the mice are immunocompetent.
Yeah, and that's good because, in that previous experiment, we realized there was a cell involved in this process. It's not just the antibody, and those cells could have been altered by the lack of interferon.
Right. Okay, so the experiment is they inoculate the virus into the foot, and they measure RNA. So they have to remove the foot. Well, they sacrifice the mice, of course, and remove the foot, the muscle, the ankle, etc. Measure RNA by PCR. 1,000-fold reduction in RNA in the ipsilateral ankles with 2 monoclonals. That's the same where they put the virus in, right? Ipsilateral. They also see dissemination of virus to the ipsilateral calf muscle, the leg, and the spleen. But not when you treat them with antibodies. You don't see any of that dissemination. given monoclonals, there's no dissemination. Only one animal had virus in the spleen. So that's pretty cool. And by the way, that monoclonal with the one amino acid change that prevents glycosylation and prevents FC binding doesn't protect from infection. I think that's a really nice control. So they don't have to use the knockout mice, the FC gamma receptor knockout mice for this. They also measure ankle swelling as a kind of pathology, and they show that ankle swelling is reduced by these monoclonal antibodies. So the monoclonals prevent dissemination and disease. Really nice, and they don't even neutralize infection. So they bind FC receptors. Which FC receptors, Brianne is thinking, on what cell types?
Absolutely. I'm guessing it's an FC gamma receptor since it's an IgG. But after that, I'm ready to go.
Yes, and of course the knockout mice were the gamma common chain that they knocked out. So the cell type, they deplete. So monocytes are NK cells. They have FC gamma receptors, right? So you can deplete those from mice with antibodies against the cell type, markers on the cell type. So they can deplete, then they can infect, and then they can give antibody. So if you deplete monocytes, the protection afforded by the antibodies decreases. These two are 100%. Now it goes to 40 and 30%. But if you deplete NK cells, no difference. NK cells, as opposed to yesterday on immune, where NK cells made nets. Here they don't do.
No, yesterday on immune was neutrophils.
Oh, sorry, neutrophils. Yes, I get the N's mixed up all the time. Natural killer. So NK cell FC receptors do not bind, and it's the monocytes. And I guess Cindy would be happy. She likes monocytes. Right?
I very much like monocytes. If I had thought more, I would have worn my monocyte necklace just to talk about this paper.
So how do monocytes do this? So they do a bunch of experiments. I think the coolest one is where they deplete virus from cell supernatants using antibody and cells. They incubate antibody, virus, and monocytes together, and they centrifuge out the cells, and they show a reduction of virus in the supernate. So the viruses are binding to the monocytes via the antibody. The antibody binds the virus. The antibody binds the FC receptor, and they stick to the monocytes. And I guess the idea is that eventually the virus particles are taken up into the monocyte and destroyed. They do
so basically the idea is that this should activate the monocyte to be phagocytic when the FC receptor is engaged.
So back up a minute. Yep. I'm not sure we got I understand, or that we got the NK cell depletion.
The NK cell depletion did not affect protection against infection afforded by the monoclonals. So no change in protective activity.
There are two big cell types that have the FC gamma receptor, monocytes and NK cells.
Right.
And so they checked both of them to see what would happen if they got rid of those cells. And if they got rid of NK cells, nothing happened. So the mice still were protected, which told them that NK cells were not the thing that was affording protection.
Right.
When they got rid of monocytes, the protection went away. And so that told them that the monocytes were the thing affording protection.
I see. Okay. So it's one of these double negative things.
Yeah.
It's really hard to think about. Okay.
So the virus particles with the antibody attached to monocytes, they did some assays to show that it's internalized. The virus is internalized. As Brianne said, the binding of the antibody to FC receptor activates the monocytes. They become phagocytic. They internalize the virus, and that's the end of that virus once it's in monocytes. Is going to be destroyed. So that's the mechanism of the ability of these antibodies to prevent infection. It's not neutralizing. It's not, and neutralizing can be blocking virus attachment by the antibody. It can do other things as well, but none of that is involved here. Here it doesn't even involve it involves binding the virus particle and then getting taken into a macrophage. I think that's really cool.
So remember that as we look at variants showing up and we look at vaccines,
yes,
their behavior, a lot of the assays that are done with SARS-CoV-2 are in vitro neutralization assays, okay? What's this? The metaphor is looking under the street lamp, right? You look where the light is. You can do those assays. But those same things don't take into account immunity, cellular immunity.
Yeah.
Neither do they take into account the potential for this kind of thing, okay, where it's not neutralizing. It's antibodies that do other things. Okay? And really important to keep in mind.
Yes, I agree, because people get freaked out when they see neutralization activity declining, but, well, first of all,
it's only part of the story. Not only that, but the epitopes that are going to do this are different than the epitopes that are going to confer neutralization. All right. So
that's right. They are different.
You could change the neutralization without changing any of this at all. And as a matter of fact, I think they make the comment somewhere in here that some of these are conserved epitopes. Is that correct? Or am I talking about, is there conservation in the antibodies?
Well, conserved in different isolates of myaro, I think. Yeah. Yeah, that's correct. They do say that. But yes, so I don't know, Brian, are you aware of anyone who has looked at similar mechanisms for SARS-CoV-2 antibodies?
There's been a little bit of work, but these experiments take a lot more time than the neutralization. And so
you'd need a BSL-3 because you'd need that for SARS-CoV-2, which limits it.
I have not really seen kind of something that's extensive and really shows all of this mechanism.
So I think it's very important that this be done and we understand the contribution, because the reduction in neutralization by these changes may not be as significant as we think it is, right? I think the T cells are clearly helping an awful lot, but I wonder how much the antibodies, the neutralization, the classic neutralization, how much they as Rich said, we're looking under the street lamp because we have an assay that is easy to do, but
I think that one thing that I've realized needs to be communicated to people more and more often is that immune responses are more than one thing.
I think this is a nuance, and part of the problem is that the writers who write about this for the mass consumption don't understand that nuance. They just want a clear, straight story. Okay, the variant is evading antibody. That's it. We're going to write that, and that's the whole story. But it's very nuanced. So this is a beautiful system to make these kinds of observations. I think it's a great model system. You have, the ability to make antibodies to the virus and examine them in culture. You got a mouse model. So I thought really good to introduce this concept that the protective ability of an antibody against disease may not involve neutralization. And I think, if I remember correctly, one of there's a cocktail of monoclonals that were used to treat Ebola virus infection. I think one of those three, made by Regeneron, is not actually neutralizing. And they threw it in there and it works better. Is that right?
Yep, I remember that.
Yeah.
They make the point over and over again in the discussion. They're not really knocking their own work. They're talking about, partly talking about limitations and partly talking about where this needs to go. This is an animal model. They need to look for what sort of antibodies are made in humans that are relevant in this fashion. Those are much more difficult experiments to do.
But, you think about this in terms of vaccine development, right? For SARS-CoV-2, they made their vaccine. They tested for neutralizing antibodies. They also tested for T cells, but they didn't do any functional. They just said, there are T cells that are virus specific. But they did neutralization assays, and they based everything on that. And there's probably more. I don't know why it was a matter of expediency. They decided that neutralization was the property they were going after. I think they got lucky. You took the words out of my mouth. I hate to say lucky because there's so much skill involved. Yeah.
Okay. But it could have turned out otherwise.
Well, I think they had some previous information about the importance of neutralization with some of the other coronaviruses. Mm-hmm. And so they said, let's assume that those same things are the case. I don't know how much they looked into these other functions with those other coronaviruses in making that argument. But they said neutralization seems to work pretty well for these other coronaviruses. Let's go for neutralization.
So neutralization works well, meaning there's a correlative protection of neutralization.
Yes, exactly.
Versus what? Disease in an animal model or something? Is that?
I believe so.
Yeah.
I think the developers also had their eyes on the cellular response from the get-go. There wasn't as much data on that because the experiments are harder to do.
Yeah.
But there was always a component of the analysis that says, let's be mindful of the cellular response because we know that's important.
Interesting word you used there.
What?
Mindful.
Which word?
Mindful.
Yes. This paper, as well as the paper we talked about on immune yesterday, which was also about a non-neutralizing antibody function for those of you who were not there, have both made me more mindful of how I am putting together my functions of antibodies lecture for my fall immunology class. I feel like I maybe undersell things. I mention things other than neutralization, but I'm not sure I focus on them a lot. And now I'm realizing from both of these papers that I want to change how I talk about them.
Yeah, I've always had a figure that has different ways to neutralize besides blocking attachment, because that's what we're thinking. But I want to now, have another one with other non-neutralizing mechanisms of protection. I think that's a good idea. Yep.
2 comments to make about this paper. One is about the second author, because she's a graduate of the University of Michigan, Autumn Holmes. I met her several years ago, first at the Maryland ASV meeting, and then at the Minnesota meeting. We ran into each other again, kind of intentionally. And so I missed seeing her these last 2 years. But she trained in Bert Semler's lab, so she worked on picornaviruses, and seeing the kinds of things that were done in this paper, it's like, wow, she's got a whole new skill set, depending on what she did. I didn't have time to connect with her and find out what exactly was her expertise in this. And then the second thing is just a comment, and it comes up in a lot of papers, and this is paywalled, so it won't work for most of you, but Figure 3 is a set of graphs of survivals of animals. And they present the graph, and then they present the legend for each of the different color curves in the same order that the software program spits them out. In this case, it's most likely PRISM, and it's most likely the order in which the data were entered, because in fact, they're antibodies listed in numerical order. And it could be so much clearer for someone to look at the figure, particularly in a oral live presentation, but also in reading paper. If you would take each of those legend pieces and rearrange them so that they are closest to the curve of interest. So for instance, the red and the blue curves are on the top. Right. If you moved May 10 and May 108 to the top, those are the most protective, and it's very easy to see that and match that up with the data in the paper. So this is a trick that I learned from Jean-Luc Dumont, and I try and teach it to people whenever I can. And
it's a good idea.
Just makes it much easier to grasp in a hurry.
Yeah.
This paper is actually open access.
Oh, it is?
Nice.
Oh, that's right. I just now saw that. Yes. Cool. So you can check it out.
All right, let's do some picks. Brienne, what do you have for us?
So as I sort of mentioned a second ago, I'm really into thinking about my courses for the fall and in planning for courses. And I was going through my course website and came across this link that I use in some of the classes to some games from the Nobel Prize website. So the Nobel Prize has a set of educational games that are related to different Nobel Prize winning achievements.
Nice.
So I use the blood typing game when I describe how agglutination works in talking about blood typing. And so I've used that every year. I was coming across that. But they have actually quite a few fun little games here where you can learn about conditioned learning or chirality or x-rays, so the cell cycle, things like that. So these are a lot of fun. I find that the blood typing one makes the point that I want to make in class really well for my students. So I think these are neat little games that they have.
That's great. That is just great. Good for the Nobel site. Nice. That's really cool. Rich, Kathy, what do you have for us?
I picked something that's a YouTube video put out by the U of M, and it's a really cool story about, now I forget what exotic island place these snails are, but the native snails are mostly all extinct except for one species, and they were trying to figure out why that was. And in fact, a hypothesis was presented maybe almost a century ago, but they were able to finally follow up on that. And the hypothesis was that the snails that were surviving liked to be or spent more time in the sun. And so what they did was make these tiny little photosensors in conjunction with the engineering school here, and put them both on leaves and on the snails, and show that indeed the ones that survived spent more time in the sun. It's just kind of an amazing coming together of biology and engineering.
That's great.
Hypothesis testing.
Makes perfect sense to me. I home to the sun.
Yeah.
Yeah, after spending so many years in Buffalo, I guess you would, right?
Yeah.
Rich,
This is great. I think it's Tahiti.
Yes, thank you. Yeah.
Rich, what do you have for us?
I have a book called In Shock, My Recovery from Death to Recovery and the Redemptive Power of Hope by a woman named Rana Audish. I believe that this was a New York Times bestseller from a while ago that I read recently because it came up in the context of this annual conference in honor of my sister-in-law at Beth Israel Hospital. And basically this is an autobiographical account written by a physician, Rana Audish, and in my pick, I linked to her the description of her on Wikipedia, where fairly early in her career, though she was an attending at the time, I believe, she was pregnant and had a near-death hemorrhagic experience that was misdiagnosed because it resembled a late pregnancy bleeding disorder. And that misdiagnosis actually led to a longer struggle over a period of years, really, to finally figure out what the problem was and address it. It was some benign tumors in her liver. She had a god-awful experience and was near death more than once. And importantly, this is one of these classic doctor as patient stories. Okay, where now she experiences medicine from the perspective of a patient and comes to realize where a lack of compassion can have such a profound negative impact on the patient's experience and, maybe even their well-being. And she talks about how the medical profession in trying to traditionally in trying to cultivate a certain amount of resilience and toughness in physicians, basically trained people to suppress their otherwise compassionate instincts, and that's counterproductive. And this turned her into an advocate for compassion in medicine, and it's a great story.
Did you mention this Friday to?
I was just going to ask that same question,
Kieran. I think someone mentioned a book. Was it you?
I think
yes, I may have mentioned it, and that's why it came back up into my head. Yes, I think I mentioned it. Yes, I did.
Yeah, you asked her if she'd read it, but she hadn't.
I asked her if she'd read it. That's right.
Okay. So I was just opening my lecture to make this change so I don't forget. And I want to show you what comes up here. Here we go. So this is a slide on neutralizing antibodies, right? Defense, neutralize virus particles, blah, blah, blah. Not all antiviral antibodies neutralize infection. then I never go any further. I never tell them. There's no, the next slide is a neutralization assay. And
Right.
then there's an experiment about how you can protect, why doesn't it move ahead? There, you can protect animals against polio with it passively, but I never say, so now I'm going to add some slides here to do that.
Yeah, so I have slides in immunology about the 5 functions of antibodies. But it's really all about neutralization, a little bit about a couple of the other ones, and the other last ones exist. And I feel like that needs to change a little bit.
Actually, I do have some more. Here, let me just, pardon me for showing things. I'm sorry, guys.
I do love to talk about opsonization.
So here I show different ways that antibodies can neutralize, not just by blocking attachment, but endocytosis, uncoating, and so forth. And then I do have, look, I have ADCC, Brienne. I have one
It's good.
non-neutralizing where the antibodies, here it's an infected cell the antibody is binding to. And the NK cells are causing them to die. It's good. So there is one, but I'm going to add more, so that's fine.
You should make sure to talk about opsonization. That is still one of my favorites from when I was an undergraduate in my undergraduate immunology class, because I still have my first exam and I got it wrong on the exam because I remembered the analogy the professor taught, but I didn't remember what it meant. He said that opsonization was like putting butter on something. It was coating something to make it more likely to be eaten and to make it look more tasty. And so my definition of opsonization was butter.
Excellent. That'll make you remember things, won't it?
Exactly, yes.
All right, I have 2 picks. The first is an article sent to me by Jeff, thank you, Jeff, for sending this. Jeff is who's our fundraiser. And this is in Medium by Ingu Yun, MD. The Provincetown COVID data is actually good news if you're vaccinated. And it's really good. It's a really nice explanation of why the data are not as bad as some are making it. We're hearing nothing but bad news stemming from the recent outbreak of COVID in Provincetown. The majority among fully vaccinated people. The war has changed, CDC has said as they issued the report on the Provincetown outbreak, or as they say, a town in Barnstable County. Oh, this is the paper. This is the MMWR.
This is the one.
It's Provincetown in Barnstable County. On the surface, it looks frightening. Nearly 1,000 cases have been reported from a 2-week period in Provincetown, 75% fully vaccinated, 7 hospitalized. Viral load, we talked about this, higher. And look at this. The CDC equating viral load with infectivity is now recommending. So this person gets it. The problem with this messaging is that it increases the fear in vaccinated folks when that fear is unfounded. And it sends a message to the unvaccinated that vaccines aren't working, which is completely wrong. And then the author goes on to explain why there's a different way to interpret these numbers. He or she says it's not a controlled study. It's a report from a period when 60,000, mostly gay men, descended on a resort town to pack themselves into poorly ventilated bars and clubs every day for several days. No one was wearing a face mask. It rained a lot. Most people were indoors. How do I know this? I was there. I spent 99% of my time outside, but I had to go indoors. So he or she says it's an exceptional circumstance in an exceptional location. Then he goes through the numbers and basically says, most of these people were vaccinated.
Yeah, P-Town has an extraordinarily high vaccination rate, 95%.
Yeah. And he says,
and they're apparently, as a community, very sort of community health conscious.
Yes, they are.
He says, the numbers tell me vaccines are working, which is what we say. Anyway, it's a really well-written article. So I like it. Thank you, Jeffrey.
I saw a PBS NewsHour spin on this from Ashish Jha, Dean of Public Health at Brown. I always like his reports, and he basically said the same thing. Barnstable County, P-Town did an experiment for us. Okay. And first of all, there were 60,000 people there and only 300 or 400, I think it's up to 800 now, COVID cases. Okay.
So here's a line from the...
What about their severity?
Yeah, right.
Yeah. No. Mild.
Here's a line from the article. What about the possible increased transmissibility of the Delta by vaccinated people? Well, first of all, no one knows if this is actually true. Even CDC cautions about the interpretation of their data in the very same report that triggers the warning. So I love when I read measured articles that don't try to scare you.
Very good.
All right. The other one is an opinion piece from the Times today, a guest essay. I was the architect of Operation Warp Speed. I have a message for all Americans from Alex Azar. He basically says, get vaccinated, folks. It's not a political thing. I'm really proud of these vaccines. I helped direct all the development and funding and so forth. And he's a Republican, of course. He says, some of my colleagues are making it a political issue, and that's just wrong. Just get it. I think it's great. I wish more people from that party would do this. He says the vaccines could be a victory lap, but they're not treating it that way. They're shunning it. So it's great. I really like this. I was never a big fan of his. I thought he said things that weren't right, but this is the right
That's really
message.
That's really important that a whole bunch of people that we have never been fans of come out and do the same thing.
Yes, more people.
Right, and we thank them for doing it.
Yeah, for sure. We have a miracle. Take advantage of it. We have 2 listener picks from Jake. Hello, TWiVers. Been listening for over a year now. The information you supply is interesting and welcomed. Knowing your group's love of space, I have a pick for you. NASA keeps a database of the spin-off technologies that come from the space program. They update it every year, and I thought you might enjoy it. Very cool. This is always useful stuff, right? Stuff that we get from the space program.
Excellent.
Cool. Very nice. We need this for science, right?
Yeah, this is awesome.
Well, this is science, but biological science. And Peter writes, Dear TWiV team, I came across this telling of the story of industrial melanism in peppered moths in the style of a children's book, but carefully avoiding anthropomorphism. And Peter provides a YouTube link. Thought it would make a good listener pick. This is from the Atomic Shrimp channel. They have a fairly eclectic mixture of interesting videos. And the description is, this is a story I wrote a few years ago about Bernard, a moth whose life was quite extraordinary in a way that he would never know. Isn't that great?
Yeah,
Excellent.
I started watching this YouTube about Bernard. It's quite good. I didn't have a chance to finish it before the show started, but it's, definitely worth checking out.
And that is epitope 789. I'm sorry, episode. I just love that kid did that. I
do too.
So, Kathy, right? Some kid.
Yes, I heard, yes.
Her grandkid asked her, what epitope is this? I wonder how old the grandchild was. It's brilliant.
I thought she said, but I don't remember.
This is episode 789. You can find the show notes at microbe.tv/TWiV. Send your questions and comments. TWiV at microbe.tv. If you like what we do, support us, please. And support our venture going forward, a new studio, so we can do more science communication. Microbe.tv/contribute. Kathy Spindler's at the University of Michigan in Ann Arbor. Thank you, Kathy.
Thanks. This was a lot of fun.
Brianne Barker's at Drew University, BioProf Barker on Twitter. Thanks, Brianne.
Thanks. It was great to be here.
Rich Condit, Emeritus Professor, University of Florida, Gainesville, currently in Austin, Texas. Thank you, Rich.
Good thing. Always a good time.
I'm Vincent Racaniello. You can find me at virology.ws. I'd like to thank the American Society for Virology and the American Society for Microbiology for their support of TWiV, and Ronald Jenkins for the music. This episode of TWiV was recorded, edited, and posted by me, Vincent Racaniello. You've been listening to This Week in Virology. Thanks for joining us. We'll be back soon. Another TWiV is viral.